Morning, everyone. Can you hear me okay? Volume's all right? I see a couple of nods. Wonderful. Okay. Welcome to the Beyond Opioids panel. I'll be moderating. My name is Rob Edwards. I'm a pain psychologist and clinical researcher at Mass General Brigham, and I have the great pleasure of moderating this panel of distinguished speakers. I think we're going to jump right in. We'll go through some questions and topics of great interest to the field. I'll have the speakers introduce themselves a bit, say a little bit about their backgrounds as they're addressing some of the questions, and we'll certainly have time for audience questions as well. I'm told you can input them through an app, I think. Casey's given me the thumbs up, and they'll pop up on my screen here. And then I can have the panelists address those questions. So I'll start out just by stating the obvious, that increasingly pain science and pain management are de-emphasizing the use of opioids. This is no surprise to anyone. And so there's a desperate need for effective and safe non-opioid alternatives for both acute and chronic pain management. And so it's a real pleasure to have some panelists here who can speak to some of those issues. So we'll start out with a question regarding what our panelists think of as the biggest unmet need today in the pain management space. If it's okay, I'll just start down at the end with Paul. If you wouldn't mind kicking us off and just giving a little bit of information and background.
Thank you, Rob, and thank you all for coming this morning. My name is Paul Nigulescu. I'm a Senior Vice President of Research at Vertex, and I'm the Disease Area Executive for our pain program. I've been working on our pain program for about 25 years at Vertex, and I'm a PhD physiologist by training. With regard to the question about what's the greatest unmet need, I think I'd sum it up by saying we need better medications for severe pain, for the type of pain that isn't addressed sufficiently by anti-inflammatories, where the only option today really is to go to opioids. So try to have something else for the severe forms of pain across various pain conditions.
Thank you so much. Thank you to the meeting organizers for having me here as well. I'm Lilit Garibyan. I'm a physician scientist, innovator and entrepreneur, and also associate professor of dermatology at Harvard Medical School, working at MGB at the Wellman Center. I have spent over 2 decades at Harvard actually translating breakthrough ideas from lab to clinic, and I invented and developed an injectable cooling technology that has led to 3 startup companies. One of them is specifically focused on pain, and I'm excited to be here to share what we're working there and also my expertise in pain in general. So to answer your question, Rob, I think the unmet need is to find a therapy for pain that's long-lasting and durable, and could treat chronic pain. Chronic pain is a major issue, and it really locks our patients into daily use of medication, and also, as Paul said, that leads to exposure for some patients to opioids, which then leads to addiction. If we could find a treatment that has a long-lasting effect, it's non-pharmacologic and non-opioid, I do think we could make a huge difference in pain management.
Thanks. Thank you for having me. My name is Roman. I'm a principal on the Novo Holdings Venture Investments team. Novo Holdings invests on behalf of the Novo Nordisk Foundation, which is the largest and controlling shareholder of Novo Nordisk Pharmaceutical Company. We invest broadly in life sciences and therapeutics. We try to diversify away from our ownership in Novo, so type 2 diabetes and obesity. To answer the question, I think that subsetting patients is going to be incredibly important in this space. Rob and I were talking before the panel started about the variety of techniques that can be used, whether it's genetics or neuroimaging or things like that, to really get a better understanding of the subsets within acute pain, within chronic pain, and how to address their individual needs. And I think in general, it becomes very difficult from a therapeutic development perspective if you have to treat every single person, in an umbrella fashion, the likelihood that you're going to hit on one, home run, hit it out of the park for all of those patients, I think is very, very low. The more refined we can be about identifying these subgroups within acute and chronic pain, I think the better chance we have of developing meaningful therapeutics.
That's fantastic. Thank you. I've got some good questions coming in from the audience. I've got one more background question for the panelists, and then we'll turn to some of the specifics. So next question for us to consider is, what would you say is the biggest misconception about modern pain management, and how does your work address this misconception? And I'm going to exercise the moderator's privilege and give a brief answer myself, and then we'll go back down the line here. So in my opinion, and I'm based in a tertiary care pain management center, so see a lot of folks with a variety of chronic pain conditions. For me, the biggest misconception is that most individuals experiencing chronic pain have a single condition that can be managed by a single treatment. What we see in practice is that there's tremendous comorbidity between chronic pain conditions, and it's honestly fairly rare for a person to have just one condition. Most people are going to have a complex presentation with multiple chronic pain conditions simultaneously, and they're likely going to benefit most from a multimodal treatment package that might involve 3, 4, 5, or even more management approaches, including pharmacologic and non-pharmacologic. I'd love it if our current kind of landscape of understanding of pain management reflected that a little bit more. And I can pass it next to Roman.
Thanks. Yeah, I think a common misconception that we deal with a lot from the investment perspective is that the data alone will rule the day. In other words, just having the best efficacy is going to guarantee success, from a clinical perspective or a commercial perspective. I think we benefit a lot from having a deep understanding of the workflows of the physicians who deal with these patients in something like an acute kind of post-surgical pain setting. If you actually are able, just for example, to take your emerging agent and seamlessly fit it into the workflow, that's going to have a much better utilization, a much better uptake for the physicians and benefit for the patients, even if it comes at a slightly less efficacy than something which breaks the workflow, takes people out of their comfort zone and actually maybe adding a little bit more durability, but it comes at a cost. So I think being transparent about what really matters both for the physicians and the patients and trying to understand the bottlenecks and addressing those. It's not always intuitive, but I think that it's just the best efficacy isn't always the right answer.
Yeah, thank you. That's a great question, Rob. I think the one misconception that I would want to retire is this idea that effective pain management always requires daily repeated dosing, whether that's in forms of pills or patches. I do think if we buy into that idea, we kind of lock ourselves into this notion of developing therapies that are short-acting and are not durable enough and require daily dependence on therapeutics. Our work at Mass General Brigham that has now spun out to a startup company has challenged that paradigm. We've actually developed an injectable that's non-opioid, non-pharmacologic, that allows you to selectively target peripheral nerves and reduce pain for 3 to 6 months. So a single injection could provide a patient the ability to do their daily activities, not worry about taking pills, be able to participate in productivity of their work, and have their life back. So I do think by reframing how we see pain management, we could develop better therapies that are much more long-acting and could give patients the freedom of being able to go on with their lives.
Thank you, Rob. I think the biggest misconception I'd like to see changed is that short-term opioid use does not carry a risk of addiction. It's very clear from data over multiple years now that as short as 2 or 3 days of opioid exposure can lead to addiction. And it's particularly important for younger populations where the brain is still developing and very subject to influence by the reward system. So that's something I'd like to see changed.
Yeah, that's a fantastic point that I think we probably don't pay enough attention to. There's certainly some nice data from large studies of people experiencing postoperative pain, and we know that something on the order of 4, 5, or 6% of individuals who are initially opioid naive preoperatively will wind up on long-term opioid therapy after surgery. A number of them will potentially have issues with misuse or other negative outcomes, and boy, would it be nice to avoid some of those long-term downstream effects. So next question from the audience. What mechanisms or targets are most exciting right now in the pain space, whether it's neuropathic or nociceptive pain, and specifically, what role do biomarkers play in evaluating potential assets that are targeted at those mechanisms? If it's okay, Paul, if you don't mind doubling up,
Sure.
We'll start with you. You might have some fascinating insights about sodium channels, I'm guessing.
That's a really easy question for me to answer. I think one of the most exciting developments in the last few years is the emergence of selective sodium channel inhibitors that inhibit pain signals selectively in the peripheral nervous system. And we've been working on a couple of them for a long time, as have much of the pain field, particularly NaV 1.7 and NaV 1.8. And we have recently gotten approval at Vertex for a therapy that's a 1.8 selective inhibitor, and it's been approved for moderate to severe acute pain. And it's teaching us a lot about the potential for these precision types of medicines. So these are medicines that only should affect pain signaling. And that's a paradigm shift in the pain area, because in the past we've had therapies that are not selective for the pain pathways. They affect other pathways in addition to pain. And so we're seeing an emergence of science that says we can specifically target pain and leave the rest of the nervous system and the human body unaffected. That's a huge shift in our thinking about pain therapies in the future.
Yeah, I agree with Paul. I think selectivity is a huge area that is going to shift the paradigm for pain treatment. Being able to selectively target channels or signaling mechanisms that signal pain sensation in patients is huge. And with the technology we've developed, that's exactly what we're also doing. We're targeting selectively the myelin sheaths without affecting the surrounding tissue. So the surrounding skin, the surrounding muscle, completely unaffected with this single injectable that is done similar to how lidocaine is injected by physicians, except that this gives you the durability in the fold of 3 to 6 months as opposed to hours with lidocaine. So selectivity combined with durability will definitely be a game changer for pain management.
Yeah, it's a great question. I think I will echo Paul in a focus on the sodium channels. We recently led a Series C investment in a private company called Site1 Therapeutics, benefited tremendously from the great work that Vertex has done over the years. They also developed NaV 1.8 inhibitor, and were recently acquired by Eli Lilly, so we're super excited about Lilly taking that program over, that company over, and taking it forward. On the biomarker question, I think it's a really interesting point. Again, saying thanks to Vertex, they did a lot of really great phase 1 work around these experimental pain models, where you can do things like take a healthy volunteer and put their hand in freezing cold water, and then give them a NaV 1.8 inhibitor and show that actually lengthens the amount of time they can keep their hand in the freezing cold water. And a really kind of one-to-one relationship between the PK and the PD there was a really great opportunity for early stage companies to kind of follow in those footsteps. So I think with next generation targets beyond 1.7, beyond 1.8, I really am looking forward to folks leaning into those opportunities in phase 1 development to potentially even identify patients up front that could benefit from them, but also to really in a phase 1 setting before you have to go, do the big trial, the big phase 2, the big phase 3, see with these experimental pain models that your target is engaged in a really robust way.
That's fantastic, thank you. It's really exciting to be able to talk about some pain-specific, peripherally focused novel treatments. We have not necessarily had that opportunity in the pain management space for years, and so between NaV1.8 inhibitors and Lilit's peripheral nerve targeting non-opioid cooling device, we're going to have some nice, appealing options for managing pain from a variety of conditions. So as a quick follow-up, and if it's okay, we'll start with you, Roman. We'll do the snake draft style if you're familiar with fantasy football techniques. When we're talking about potential assets to pursue, phase 1 studies, that sort of thing, what are you most looking for in terms of signals that would get you excited about a potential asset? So you mentioned, for example, human experimental pain studies. So we can use quantitative sensory testing techniques, from cold pressor test to other things, to get a look at whether, for example, a novel compound might alter pain sensitivity in healthy volunteers. Presumably, there's interest in safety data at those phase 1 stages. You might also be looking at biomarkers or other mechanistic pathways. What sort of things do you look for in those early phases, and what might make a novel asset most exciting and appealing for you?
Mm-hmm. Yeah, thank you. I think it's exactly as you described it. I would say that there, again, a lot of great work done by other companies historically that have demonstrated with certain targets you can really lean into these experimental pain models and get a very, very clear PK-PD relationship. It's not about necessarily hitting stat sig in these settings. It can be a bit more qualitative. And so I think working with very high quality groups, and I'll just give a personal shout out to the Center for Human Disease Research, the CHDR in the Netherlands. They're a really high quality group that has been very, very focused for a long time on developing these models and leaning into them making them very robust and controlling the placebo response, which I think we all appreciate in pain models. Even some nice literature showing that over time the placebo response has increased in pain studies. So how can you address that? I think you can address it by being very, very concise with how you run these phase 1 studies. And some of these centers like CHDR have demonstrated that if you control the setting enough, you basically have minimal to no placebo response, which is really remarkable. So I would say for anybody that's kind of developing a next-gen target, making sure that you just take your time in that phase 1 setting. People want to jump straight to phase 2. That's fine, and I appreciate that. But this is one of a rare example, I think, in a variety of therapeutic areas we work on at Novo, where the phase 1 setting is really all I need to see, at least when it comes to something like a NaV1.8 inhibitor. If you show me that data, I can tell you, safety is going to take longer and you're going to need more information, but that really is de-risking, truly de-risking. But if you just have to take your time in the phase 1 setting.
Yeah. So I will answer that question from my perspective as a physician and scientist and somebody who worked on this technology for 12 years. I did a lot of animal experiments, hundreds of rats. You inject them, you do quantitative studies, you do imaging, you find out the mechanism. Very exciting. You're seeing reduction. So you're very optimistic about it. You make a startup company, they make the commercial device, you go to patients, and I think that moment of truth is really when you see the patient data, when the first few patients are injected with this technology, and you see their pain drop from 9 or 10 down to 0 or 1. I think that's pretty remarkable, and that's when I truly start believing that this is going to work, because you could do as many animal studies as you want, but it's until you see that human data, it's still a research project. And we did actually the first 16 patients last year, and now we've enrolled already 250 patients comparing this injectable to opioid for osteoarthritis pain. So we will have the interim readout anytime this week, next week, and hopefully the approval next year. So I would say, Rob, that the most exciting part is seeing the human data, seeing a human being, a patient benefit from it, and knowing that you had a role in bringing this technology to them.
Yeah, I think it's a really important question. You know, how do we qualify compounds and approaches earlier in the clinical development paradigm? It's important in all of therapeutics. But I think in pain, there's a great opportunity because you can measure pain, and you can measure it pretty easily. The challenge, I think, as Roman is pointing out, is that it's not very quantitative yet, but I think that we're moving in that direction where we're going to get better ways of measuring human pain, and we'll be able to qualify molecules earlier in the development process for efficacy. I think the other thing you mentioned, which is really important, is we're now looking in future pain medicines for medicines that are not only effective but safe. And so the safety signals and how you look for those in those early studies are really important to validate this precision concept or identify other aspects of your therapy that may not be desirable, so you can weed those out early. So big enough that you can get safety and efficacy, but I think that's possible in pain studies and maybe can open the way for us to do this more in other disease areas as well.
Yeah, that's terrific. So I have an audience question about endpoints. If it's okay, Paul, I'll probably direct this to you to start. So for a variety of really good reasons, typically in analgesic trials for chronic pain, people are looking at reductions in patient-reported pain intensity on a 0 to 10 scale over the course of 12 weeks. That is far and away the most common structure and timing and primary outcome for these sorts of trials. This question relates to whether there are other outcomes, either patient-reported or otherwise, that might be as important as pain intensity reduction. So things like function, sleep, perhaps a variety of other biopsychosocially tinged outcomes. I wonder if you could speak to the consideration of those other endpoints and perhaps even the timing of those endpoints when planning trials.
Sure, there's a lot in there. Those are all important endpoints. I think one of the things I've learned in years working in pain and talking to patients is the first thing they'll tell you is, why do you always ask me to tell you what my pain is on 0 to 10? That's not what's important to me. And yet you keep asking me that question. In fact, you ask me every 4 hours. So I think before I get into the other endpoints, I'll just make a comment that even the way we measure pain subjectively has room for improvement. What they tell us is, why don't you ask me what type of pain it is? Is it throbbing, or is it burning, or is it shooting? Because that's very different, and some of them are more painful to me than others. So ask me more if you're going to ask me. And then also just average pain, I can't remember it 6 hours ago. And yet that's what we ask them. So, you know, what's your worst pain? When was it? Was it related to activity? One of the things we've observed in some of the studies is that, of course, as you get analgesic benefit, people will start moving around more. So they might be doing more, feeling the same pain, but actually doing better because they're able to move around. So the pain score itself is an opportunity to improve, and we're learning how to do that. In terms of the other endpoints, function is super important. How do you measure that? I mean, we have devices now that can track your movements in exquisite detail. We need to incorporate those more in our studies. You mentioned sleep. That's really an interesting one because there are different kinds of sleep. There's quality sleep, and then there's being conked out, right? And so depending on just, you know, did you fall asleep? Yes, if you're giving someone a CNS suppressant, you're probably going to see improved sleep. So we want to see improved quality of sleep. Are they waking up? Are they active during the day as well as sleeping well at night? So these all are ways of, I think, even measuring human health better in any of our studies. So another way to, maybe the pain field can help us move forward in how we measure overall effectiveness of medications in patients.
Yeah. I agree with everything that Paul said. I do think that there is a huge unmet need for creating better ways to measure pain. What we have, that NRS system, is just not good enough. And I do think pain is complex. I mean, that's part of the reason why so many therapeutics have failed to get approval, because there's such a huge placebo effect. I mean, the actual subjectivity of how we measure allows itself for, control arm patients to also see benefit and improvement. So improving those markers, putting functional outcome measures, making questionnaires about how the daily activities of patients' well-being is affected, mobility, participation in physical therapy. I mean, those are all important factors, and we need to incorporate that into how we measure outcome. And I think that has to come from the FDA too, because we use the endpoints we use is because that's what's required by the regulators. I mean, even if you know that there's better outcomes, you can't just use the ones you want to use because of regulatory requirements. So that's going to require policy change as well.
Yeah. Just a little bit more to echo what everyone else said. I think the functional outcomes that can be, if you have a bunionectomy surgery, time to walk 100 meters is something that's very directly relevant for you. It's very straightforward to measure, and I think can be really robust. I think there's an opportunity for collaboration with wearable technologies in some of these things. We're not invested in the company. I just personally wear an Oura ring because I love the sleep data I get from it. I mean, I think that the sleep data is actually very high quality. I've done a number of sleep studies, and it's actually very high quality. So it's something where you can, putting a ring on your trial participants is very straightforward if they're open to it and getting quality data out of that. So I think there are real opportunities to collaborate across, wearables with therapeutics to get a better understanding. And given the title of the panel that we're sitting on, Beyond Opioids, I do think opioid cessation reduction or cessation is a really important endpoint that not everybody looks at. But if you show me with a novel mechanism of action that you can cut opioid usage in half, I really know that that's meaningful. So it's important as well.
Yeah, absolutely. I'll just note that the advent and development of some of these wearable technologies has been a wonderful boon to clinical pain scientists. And so now, for example, if you're interested in sleep, and the quality of sleep and sleep architecture in chronic pain measured objectively, you don't have to bring patients in for a night or two of polysomnography. There's wrist actigraphy that tracks quite well with those results of PSG, as Roman mentioned, from Oura rings to other sorts of technologies. You can get really good objective data on things like movement, function, sleep, calories expended, all those sorts of things that we used to try to do our best to get by self-report are now available in more objective form, which has been, I think, wonderful for the field. Audience question here. These are always fun because none of us have prepared for them. So I'll start with Roman for this one. So this question's about what does the panel think are the top handful of pain diagnoses to target going forward in the interest of reducing harms of opioids? I'll start, if that's okay. I can keep this pretty brief. Organizations like the WHO, the World Health Organization, routinely do global surveys and find that things like the burden of disability from chronic pain is greatest for conditions like low back pain, joint pain from osteoarthritis, and headache. Those are usually the big three in global surveys. Obviously, there are a lot of acute and chronic pain conditions. So even if you just take the big three, that's still only a slice of the disability and reduced quality of life and harms that are caused by chronic pain. our group is particularly interested in targeting COPCs, which are chronic overlapping pain conditions. So these are folks, often older folks, who have a number of diagnoses, including things like back pain, fibromyalgia, conditions that used to get considered functional pain disorders like irritable bowel syndrome, headache, temporomandibular joint disorder, that sort of thing. These sorts of pain conditions are highly comorbid and have proven quite difficult to manage in a variety of settings. So we're currently looking at those sorts of diagnostic clusters in terms of targeting non-pharmacologic treatments. And now I can ask Roman for his opinion as well.
Yeah, thank you for raising migraine. I do think that's a really interesting one that kind of gets lost sometimes in these discussions. It's a really important topic, and there are very interesting modalities that are being pursued in migraine that I think there's a real opportunity to think about them, in other settings. And just one that again we're personally invested in is a psychoplastogen and psychedelic medicine that's currently trialing in postpartum depression, recently had a positive phase 2, but there's a lot of really interesting IST data around cluster headaches with those kinds of medicines. And I think it does open the door for, again, more of a collaborative, relationship between the kind of peripheral and the central types of pain. I think, from a large shout out to the FDA. I do think the guidance around this has been actually fairly good. If you look at the label for Vertex's approved drug, it is very broad. And I think that for acute pain, I think that's fantastic. They could have taken no pun intended, they could have taken a scalpel to it and parsed, all the different patients that were involved in their trials, and they didn't. And I think that's actually incredibly valuable. So more than anything else, so you brought up a lot of really excellent ones, low back pain, osteoarthritis, et cetera. But I would just say, keeping the balance and keeping in mind that the FDA actually, in my opinion, has been pretty friendly when it comes to drug development in this space. So I think just trying to continue that collaborative aspect and look for bringing in new modalities that are maybe be counterintuitive. For example, a psychedelic medicine for cluster headaches, I think could really allow us to expand the opportunities for drug development.
Yeah, I think you guys already brought the key ones out. In my opinion, chronic pain, hands down, is really the one, especially related to osteoarthritis and hip. That's the reason why we picked our initial 2 programs to be focused on that. There's just huge unmet need in that area. These patients become dependent on daily drugs, therapies, and none of them are long-lasting. And we just really need to make a difference in their lives because it affects every aspect of their life. Even though it's one small area of pain, it really does reduce quality of life enormously for this patient. So to develop something that's long-lasting, durable, it's a game changer for this patient.
I don't think there's a wrong answer for which pain state is the most important or has the highest unmet need. There's unmet need across every single pain state.
Mm-hmm.
That's what's so exciting about being in this field, is the opportunity to affect lives in so many different ways. I'd say that one thing that we've observed is that acute pain is really maybe unrecognized in its significance because of the number of people that are affected. It's true it's shorter duration and usually the pain resolves, but when you consider that 80 million people in the US are prescribed a medication for acute pain every year, and 40 million of those contain an opioid, to me, like, getting in front of the opioid is really important for unmet need in acute pain. Having something so people don't have to take that and don't have to take it home. For chronic, I think for us, we've been looking at neuropathic pain as a particularly interesting area because it is pain that's coming from the nerve itself. And if we are targeting the nerve with these selective inhibitors, which are expressed on the nerve, there's an opportunity to really affect neuropathic pain specifically with these medications. And other medications don't work very well. Opioids don't work, although people take them, and the NSAIDs don't work because the nature of the injury is at the nerve itself.
Yeah, absolutely. So that we don't run out of time, I'm going to ask this key question. If we finish up with this, there are a couple other excellent audience questions that I hope we have time to get to, but I guess we'll see. So last question, what do you see as a potentially important paradigm shift happening in the field of pain medicine or pain management over the next 5 years or so? I'm going to start with Paul, but I will again exercise the moderator's privilege and offer a 30-second monologue of my own. I'm also going to cheat and mention 2 possibilities. One, from my point of view as a pain psychologist, has been the availability of app-based delivery of treatments that we know are efficacious for lots of chronic pain conditions. So if we know that, for example, cognitive behavioral therapy or acceptance and commitment therapy or mindfulness meditation-based treatments are beneficial in reducing pain and improving function for people with lots of conditions, that's wonderful, but those treatments haven't been accessible for tens of millions of Americans for a variety of reasons. If we can effectively deliver those treatments digitally by app or similar mechanism, that opens up an enormous world of accessibility and scalability of those potentially really beneficial treatments. That's number one. Number 2, I'm personally incredibly excited about psychedelics and their potential for chronic pain management. At this point, we just have data from a few small trials that are quite encouraging. There's some work being done on phantom limb pain, other neuropathic pain conditions that's just coming out. But some of the psychedelic outcomes data has been so impressive for pain-adjacent conditions like depression and post-traumatic stress disorder and substance use disorder. All of these things share central nervous system correlates with chronic pain, and the psychedelic data for them has been exciting enough that even a psychologist like me is getting pretty jazzed about the future of those potential compounds for pain management. Okay, that's more than 30 seconds, but Paul, you're up.
I think the paradigm shift is related to the nature of this session, which is that in the next 5 years, we will see a shift away from opioids as the only choice for people with moderate to severe pain. I think we're going to see that. I think there are new mechanisms such as the NaV 1.8 that are showing that it is possible to reach pain in different ways. And you mentioned some other ways as well. So I think that there is now a galvanization of academia and industry. Regulators are also helping to just open the aperture to move away from opioids. So I think in the next 5 years, we are going to see that happen in acute and chronic pain.
Yeah, I think we also touched on this already, that paradigm shift, in my opinion, is the selectivity of the therapies we're going to develop. As we already mentioned, what Paul said with NaV 1.8 or with selective myelin therapy for what we're developing with our injectable non-pharmacologic therapy, but also selectivity coming from RNAi or some form of gene therapy where they're specifically targeting these receptors or ion channels in the dorsal root ganglion. Because I do think at some point we're going to shift from just treating the symptoms to actually targeting the cause of the pain. And that's going to be huge once we get there. I do think it'll take more than 5 to 10 years to get there, but that would be a new paradigm of how we go from just treating symptoms to actually correcting the problem that's causing this chronic disease.
Yeah, thanks. I think it's a really important question. I really like the idea, and I'll say this as an investor, we oftentimes will argue about what the bar is. You know, how do you break into a field? And I think a paradigm shift for us really has been around, the goal isn't necessarily to be statistically significantly better than opioids. Right? Investors often want something that's better. Yeah. And I think in this case, the paradigm shift is that turns out opioids are very efficacious. They're not good drugs, but you know what I mean. They're quite good at doing what they're supposed to do. So when you look at the the phase 3 studies run by Vertex, for example, you'll see that they included an active comparator in those studies. I don't know if that was the FDA asking for it or if it was they did it themselves, but it's amazing they did that. And it was amazing that they were able to see that a NaV1.8 inhibitor essentially was the same, as a very active comparator. So I think just really understanding that if you have an agent that is as good from an efficacy perspective, and then it provides all these other downstream benefits in terms of not being non-addictive and having durability, like the other device that Lilit brought up, I think it's really just an opportunity to kind of the paradigm shift can come through not necessarily being better on efficacy, but being better in other ways.
Yeah. That's a fantastic and optimistic way to conclude, I think. We're just a minute or two over. I'd like to thank our panel. This has been a wonderfully informative and exciting session, and thanks to you all as well. Please enjoy the rest of the meeting.
Thank you.